What's up, you guys? It's your boy Miguel here to give you your daily dose of radiation. In today's video, we are covering image critique as an X-ray tech student at the hospital or during clinicals. So to give you context, I'm a night shift X-ray tech. I've been doing it for over 4 years. Trauma 3ER in the great state of Texas. So when Miguel was a wee lad student during the COVID epidemic and I was going to clinicals, I would say the beginning of my clinicals is when majority of all the image critiques happened mainly. And it's because, you're still learning, you still don't know how to use equipment, or you struggle using the shitty equipment they have. Every hospital I went to as a student had their own little shitty equipment, or newer, shittier equipment, and you just weren't ready to use it, or you struggled maybe between angling the tube to like hit the board at being parallel and getting the optimal images and angles and stuff like that, or maybe positioning wasn't as good or stuff, whatever it is, as typical student activities. And I remember many times as a student, it really depended who the tech was. You had the strict techs, you have the techs that were more willing to learn. Other techs, if you mess up too many times, they would proceed to complete the exam and not show you how. They would just get the job done, and it all kind of depends tech by tech. For me, I can give you examples of different ones. So for instance, the most strictest by the book would be the ones that we would shoot it and they look at it and they look at me and they're like, okay, Miguel, how can we fix it? Or, hey, Miguel, does it look rotated? And then you look at it and then you look at the patient and you're like, it does look rotated. And they'll be like, how do we fix it? And where's your marker? Or you see the way that the wrist, that's not completely overlateral, completely lateral, that it's oblique, that it's this, that's that. They would like critique you on the images. And sometimes, now looking back at it, it all kind of depends the text. Sometimes I feel like if a tech would shoot some of the images that I shot, they would be like, it's fine, it's whatever. But since you're student, certain techs, they want it textbook. They want to, show you the most correct way to do it, which is fine, Some of the times I look at it and I'm like, that's not that bad. But once again, you're still not certified. You're still just the wee student, So they always try to, certain texts ingrain you in the most perfect way. So there's those texts. There's other texts that it can be, still within, like, it maybe it's not super overlapped, and they'll be like, it's fine, whatever. Like, we're in the trauma room, we have a bunch of other exams, keep it pushing, like, it won't be critique as much. I've noticed that majority of my main critiques were like walkie-talkie patients, or in the main radiology, or if we were in the emergency room and we brought the patient back and they were kind of stable, that's when more of the critique, or even after the exam was done, some of the critiques would happen. Because if the patient's dying or is in the trauma room and you're shooting it many times, majority of the times the most critique you're going to get is like, it's over rotated, angle the tube. Or if you're a student and you're like, it's like this, and then certain techs would just take over and be like, this is what we're going to do, just watch me, boom. And they'll show you how to do it. And sometimes they would just completely take over. Other times we would go back and all the images that I shot that weren't like the best, they would, go back and critique, or even more about like the anatomy and be like, oh, what's this, what's that. We had some of those critiques. Or as far as even how to hang stuff, or like the correct way of the image, like for instance the chest to view, the way it's supposed to be facing, especially with the spines and stuff like that. They would educate you in that. Especially as a student, sometimes you accidentally would mark stuff wrong, and the text would like let you know, because unless they have sinus inversus where it's flipped. It's quick to tell. Now, if a student marked it wrong, I can quickly tell right away without even looking at them, but just based off of the image if it was marked wrong, just like based off of how the image comes out. Let's see what else. I remember even now looking at students that we have, some of the biggest problems I see is like the way they align the tube, or even the thought of, most of them will try to position them correctly and just shoot it straight down. Sometimes when I told them, like when the patient can't like maybe fully turn their wrist or something, that the aspect of angling the tube to compensate sometimes throw certain students off, or they'll angle too much or not enough, and that'll be kind of, you can tell in the picture, even if you don't look at the patient's positioning, just based off of the picture. Some students struggle with that, or even how you position the actual portable machine to get the image, because like with certain ways that you park in the room, you can angle the tube certain ways. So if you park it wrong, you can't angle the tube as much to compensate if the patient's unable to be positioned. Or even if like for a forearm, certain patients can't exactly be positioned AP forearm. That's the way you're supposed to do it. So PA forearm, some of the students don't grasp the idea when you're like, okay, shoot it the other way. And you're like, what? And then you're like, shoot it PA, or shoot it AP, or shoot it. Some of the students will get those confused. It happens a lot. Certain techs are like very, very strict, and you know what? It is their license. You're working with them. At the end of the day, to each their own discretions. I know that for sure if it's in the trauma room and there's a lot of stuff going on, it's just going to kind of be like, we're either going to keep it pushing, or I'm going to shoot it and fix your problem and we'll critique it later, because sometimes you only get one shot to shoot it, or sometimes you'll be trying to you'll shoot the image and then the tech will try to fix it, and then the patient maybe is not the best condition and your image will be better than the tech's, sometimes, depending on what's going on. So it all kind of depends, really, who you're with, what you got going on, their critiques. Some of the critiques will be like, oh, okay, it was a good job. There's other techs that will nitpick you for every single thing, and then you look at them with their images or with other techs, and the critique won't be there. Because the critique between me and a student versus me and another tech, it is different. I'll make a whole different video on that, because it's a whole different ball game. I know certain students will get mad that they feel like that the tech will always adjust things. Like they'll adjust it and they'll be like, okay, that's good. And they won't want to shoot it because they have to adjust the tube and they'll angle and they'll do this stuff. Sometimes I've seen other techs do that, and I'm like, yo, it's fine. Like, it would have been fine. And then the student will get on their feelings or start, fighting back the tech. Like, why would you do that if it was fine? At the end of the day, they are certified. You're not. Maybe they saw something. Because, like, sometimes you can be next to the patient and you'll angle the tube and have everything. And then from where I am by the portable, and I'm like, yo, if you shoot it, it's going to be off. Or you're not angled enough. Like, different angles, you can see different things. Like, you can tell that if they shoot it, it's not, the projectile beam is not going to hit it, or it's not going to be obliqued or whatever, it's to compensate for whatever you're trying to shoot. Like, you can tell easily. Certain students will get offended by that. So, to each their own, I guess. I was pretty chill as a student. Even now as a tech, I'm pretty chill. I won't criticize no one too bad, because I know they have a lot of stuff going on. Obviously, I'm not going to let you send something that's like really, really bad. I'll be like, yo, we can't do this. Like, this is how we can fix it. Or even sometimes, depending on what's going on, that it's not going to be pretty regardless, even if I shoot it. It's not going to be the best, and all you can do is notes. Because there's times where the student will shoot it, and they're like, "Can you do it?" And I'm like looking at it, and I'm like, "That's probably the best you're gonna get, buddy. Like, look, it's broken, it's this and that, whatever." Obviously, if you're in front of the patient, you can't be really telling them, "Oh, it's like broken." That's probably the best, you know. Other times you just look at it, and then you look at the student, and then you just like just go on to the next one. They're like, they'll start asking questions, and sometimes I'm like, just go on. I'll tell you in the room. Just keep it going. And then you kind of explain to them like, yo, this was wrong with them. This is broken. Usually, yes, we would compensate it, but look how it is. And it's like, it's probably the best you're gonna get. But anyways, it's been your boy Miguel. We'll see you on the next one.